now have is you have the organism embedded inside those fibrin platelets, inflammatory cell, and covered with more of this platelet and fibrin to shield them from the host immune cells. So that is what you have, and what happened, they keep increasing in size, and from there, what can happen? That can lead to local destruction of the valves if it is around the valve area. So you can have valve perforation, you can have worsening of the regurgitation or whatever you have there. Then there can be extension to perivalvular apparatus here, leading to the formation of abscess. And as well, these vegetations, they are very mobile. And as they keep increasing in size, you can have break-off, where you now have embolism to distal sites, to the brain, to the kidney, to the spleen. So, and also what can happen, there can also be immune-mediated reaction that also leads to many of the symptoms that we will see as we continue in the presentation. And I talked about the change in the epidemiology. There's also been a slight change in the spectrum of organism in infective endocarditis. What we used to know in the past is the commonest organism, especially causing community-acquired infective endocarditis, used to be the Strep viridians. But over the last decade, this has also changed because Staph aureus now is now the commonest organism causing both the native valve, prosthetic valve, community, and also nosocomial infective endocarditis. So this is what we have now. The table I showed, this table was in 2015, but this is what we have now. So all in infective endocarditis cases now, Staph has taken over with the streptococcus organism followed, and enterococci now the third. But the little difference in patients with prosthetic valve endocarditis is there is high incidence of the coagulase negative Staph organism in patients with prosthetic valve endocarditis, but in all, it is more Staph aureus followed by Strep viridian, then the enterococcus organism. And so classification can be done based on the clinical cause, based on the valve, based on diagnostic criteria. So the classification can be in many different ways, but I'll just talk at this point about acute or subacute. So acute, what you have there, you have a rapidly progressive illness. And this is usually caused by Staph aureus because of the high virulent nature. And here, most of them may not have any underlying cardiovascular condition, but once this happens, the course is very rapid. The patient presents with very high grade fever, and you can see other manifestations. In subacute cases, this runs an indolent course caused by other less virulent organism. There can be immunosuppression. Patients can have diabetes, cancer, all those immunosuppressive conditions, and there's usually presence of an underlying cardiovascular condition in this group of patients. And like I said, it could be native valve endocarditis, prosthetic valve endocarditis, and as we go on, we'll talk about definite, i.e., probable and rejected cases. And so quickly looking at clinical presentation. The clinical presentation of patients with infective endocarditis is highly variable, non-specific, because most of them will present to you with constitutional symptoms, fever, fatigue, dyspnea, and all other conditions that you can find in other febrile conditions. But there should be a very high suspicion of infective endocarditis when you have fever in the presence of all those cardiac risk factors that we mentioned. You have a patient with valvular heart disease, or patients with past history of infective endocarditis now having fever, especially high grade, that you cannot explain by any other reason, then you should suspect that this patient may have infective endocarditis. And we used to talk about the triad of fever, a new onset murmur or worsening murmur, and when you have evidence of those embolic issue I talked about later. So fever is the commonest symptoms you will see in patients with infective endocarditis, and in some studies you can find it in up to about 90% of patients. Then I talked about new or worsening murmur because of the valvular condition that you find in them. And like I said, mitral and aortic valve are the valves that are mostly affected in patients with infective endocarditis. But in intravenous drug user, what you have is more of right-sided endocarditis, where you have the tricuspid valve being involved in about 80% of them. And when you have the right side being involved, the septic embolism is going to go to the pulmonary circulation, so you can have lung abscess, pleurisy, and all other pulmonary manifestation. And because of the close proximity of the AV node and the ACE bundle to the aortic roots, to the mitral annulus, and also to the insertion of the septal leaflet of the tricuspid valve, there's also high risk of having conduction disorder. So you can have from second-degree AV block to complete heart block in this group of patients. While an heart failure is the commonest complication following infective endocarditis, some studies have said it can happen as high as up to 70% in patients with infective endocarditis. So we must be on the lookout for that. So you can have a patient presenting with symptoms of heart failure with high-grade fever, and you have to suspect that the patient may also be having infective endocarditis. So what are the embolic phenomena we talked about, which you can see in about half of patients with infective endocarditis? So you can have septic embolism to the brain. So patient can present with cerebral abscess. Patient can actually present with stroke. And in some patients, this is even going to be their first presentation. What you will see is patient presenting with stroke, fever, and you just have to walk your way back to the heart to look. And that is one of the reasons why patients with stroke, echo is an important diagnosis that you must do in them to be able to see what is happening in the heart of the patient. So you can have embolism to the kidney, to the spleen, to the peripheral circulation. And like I said, the right-sided IA goes into the lungs, and you have the pleurisy, hemoptysis, and dyspnea. And there's also, because of the immune reaction, there's also a lot of vascular phenomena where you have petechial hemorrhages in about 30% of them. You have the non-tender lesion on the palm and the soles of the feet, which we call Janeway lesion, splinter hemorrhages on the fingernails, and the ulnar node are tender, while the Janeway lesion is non-tender. The ulnar nodes are found on the pulp of the fingers and the toe, and in the eye you can find the retinal hemorrhages that we call the rough spots. This is not common, but you will see it more in patients with subacute infective endocarditis. And like I said, stroke may be even the first presentation in this patient, or patient presents with features of cerebral abscess because of the septic embolism that has been sent into the brain. And like I said, this may be the first presentation you will find in some of these patients. And when you have the kidney involved, you can have renal infarction. Patient can present with glomerulonephritis, where you have patient presenting with flank pain, hematuria. So all this should raise our suspicion why you have this in the presence of high-grade fever and a new murmur. If you have seen the patient before, a worsening murmur. Then like I said, it can also go to the kidney, you can have splenomegaly, the joints can be affected. So you can have patients just presenting to you with fever, joint manifestations, and you may be thinking of connective tissue disease. But like I said, presence of high-grade fever, you listen to the heart, you are getting a new murmur, you are getting a worsening murmur, and then you need to go ahead and do some other investigations that we'll talk about so that you'll be sure that you are not dealing with a patient with infective endocarditis. So, investigation and diagnosis. The three key points for the diagnosis of infective endocarditis has to do with the clinical manifestation, identification or isolation of the organism, and imaging technique to identify changes in the heart or to find the complication. So in the past, if you look at the previous DIFS criteria that was used, blood culture is the main identification test for microorganism. But by the time we talk about the update, we will see the new things that has been added. So it is no longer only blood culture. And if we also cast our mind back, we will know that what we were taught in school is take 3 samples, at least 30 minutes apart, at the height of the fever. But with the new updates now by the International Society for Cardiovascular Infectious Disease, the first thing that has happened is, number one, is there is no specification of timing again. That has been discontinued. And the need for separate venipunctures, as in waiting for 30 minutes, 1 hour between the first and the last sample, has been discontinued. Then, like I said, they've also added some extra microbiologic tests to the major criterion for the diagnosis of infective endocarditis. So we'll talk more about this in the next few seconds. And then we should also not forget that with blood culture, there could also be blood culture negative endocarditis, which you see in about 10% of patients with infective endocarditis. And some of the things that can result in this is if the patient has been exposed to antibiotics before you take your sample, and that is why it is very important to take your blood sample for blood culture for both anaerobe and aerobic culture before you start the patient on antibiotics. And also, there are organisms that you cannot isolate by the routine culture techniques. So in those patients, you can have what you call the initial blood culture negative endocarditis, but by the time you use the appropriate technique, you'll be able to identify this organism. And you have some organisms that either grow slowly or they require special medium for their cultivation, fungi, the brucella, and all this. So in this group of patients, you can have what we call a blood culture negative endocarditis, which does not rule out infective endocarditis. Then other general investigation, your anemia, leukocytosis, hematuria, like we discussed in patients with glomerulonephritis. So all these are present, but they are not specific. You cannot use them as definite marker for diagnosis of infective endocarditis. Your ESR, C-reactive protein, procalcitonin, we talked about serum lactate last week when we were talking about sepsis. All these can also be done. They are elevated, but they cannot be used as a diagnostic marker, but they are all elevated in patients with infective endocarditis. So your chest x-ray, like I said, in patients with septic emboli, they can have lung abscess, they can have infection in the lung. ECG is important because, like I said, they can have different conduction abnormality, first degree, second degree, complete heart block. So you will see it in this patient. Then echocardiography is very important, extremely important. In the past, echocardiography was the only imaging modality that was in the diagnostic criteria, but as we will see, there are new additions. And you can do both your transthoracic echo and transesophageal echo. Transesophageal echo has higher sensitivity than transthoracic because it could see very small vegetation, and it's also more sensitive in picking perivalvular abscess and all those other valvular damage more than patients with more than when you do transthoracic echo. And transesophageal echo is also important because when your transthoracic echo is inconclusive, the patient has to do a transesophageal echo. When you have a negative transthoracic echo with high index of suspicion for infective endocarditis, the patient has to do a transesophageal echo. When your transthoracic echo is positive, but you want to confirm, because you can do your transthoracic echo, and like I said, you may not be able to see other paravalvular structure or identify those complications. So you need to do a transesophageal echo for you to be able to see whether there is abscess, pseudoaneurysm, whether there is fistula. Then in patients with prosthetic heart valve, your transesophageal echo sees better than transthoracic. TEE sees better than transthoracic echo. So in most cases, you will need both your transthoracic echo, at least at the first look, then you can now go ahead and do your transesophageal echo. And like I said, in the former Duke's criteria, echo mainly is the only imaging modality. But in the updates that has been done now, other imaging modality has been added. There's been addition of cardiac CT, and there's also addition of positron emission, the PET scan, where they are available. And why do you need to do CT for the patient? As good as your transthoracic and transesophageal echo is, you can still have some patients where both may not give you any result. Both may be negative. And so in this patient, using your cardiac CT now comes into play. So the cardiac CT, the ability to detect vegetation is less than that of echo, but it has a higher sensitivity for detection of paravalvular lesion. So the new recommendation encourage the combination of both cardiac CT and echocardiography, as both of them has been seen to have superior sensitivity than when you do one alone, whether you do echo alone, irrespective of the type that was done, whether TTE or TEE. But when you combine both, the sensitivity and the chance of picking all the perivalvular complication is very high. Then the PET scan, where it is available, has also been added as a major criterion. And this is especially important when you are suspecting infective endocarditis in patients with complex cardiac implants. So patient has multiple prosthetic valve, patient have combined aortic valve and aortic grafts, and in some congenital heart disease, this has a very high yield, and you will be able, because the new studies that they use to add this new imaging technique, I said there are many cases that had previously been designated as probable, that when they use this new imaging technique, they found those things, and they were able to say these are actually confirmed cases of infective endocarditis. And so, like I said, there was an update done on the DUCE criteria in 2023, and this is what we have now. So those points in bold letters are the new improvements, are the new updates done on the previous DUCE criteria. So what do we have now? So we have groups of typical organism and atypical. For typical organism, what is needed now is 2 or more separate blood culture. Like I said, the issue of timing is no longer there, and the issue of waiting for 30 minutes in between sample has been discontinued. So, but if you are suspecting atypical organism, you need 3 or more positive culture before you can use that as a diagnostic criteria. Then other laboratory tests that has been brought in now are PCR and other nucleic acid-based technique for identification of all those organisms that would have otherwise been classified as negative culture bacteria endocarditis. So there's been those new additional laboratory tests that can be used to isolate those organisms. And like I said, in the imaging, it used to be only echo, but there's been addition of cardiac CT and addition of PET scan. Then there's a new addition, which is the surgical major criteria. So when you don't have echo, you don't have cardiac CT, you don't have PET scan, but the patient had other reasons to do surgery, and the surgeon could see vegetations on the valve, could see all those perivalvular abscess and other things, that on its own is now a major criteria, which is a total new. So when you have evidence of infective endocarditis documented by direct inspection during surgery, so you don't have other major criteria, then this is now a major criteria now. So for our minor criteria, what are the new additions? Previous history of infective endocarditis has been added, and implantable cardiac devices has also been added, because like I said, due to the change in the epidemiology, in the age group that is affected, so patients with pacemaker, patients with ICD, all of them now is a minor criteria for infective endocarditis. Yeah, our fever is there. All those, our vascular immunologic phenomenon has always been there. Then those other new lab and new imaging modalities that they cannot meet the major criteria has also been added into our minor criteria. So the diagnosis, like we used to know, you need either 2 major criteria or 1 major criteria with 3 minor criteria or 5 minor criteria to make your diagnosis. So your diagnosis can either be definite, where you use those criteria that I mentioned, or you use the pathology criteria, where you are able to identify the microorganism from the vegetation, or you use the clinical criteria. Possible criteria, you only have with 1 major criterion and 1 minor criterion, or you have 3 minor criterion. And when you don't have any of these, then the diagnosis is rejected. Where you have a firm alternate diagnosis, or newly added when you have lack of recurrence, when you have used antibiotic for less than 4 days, you have treated with antibiotic for less than 4 days, and there is no fever, there is no other clinical manifestation, then most likely it's not infective endocarditis, because for appropriate treatment of infective endocarditis, before you have resolution of symptoms, at least you must do about 10 days. And the duration of treatment is between 2 to 6 weeks. So if you have used antibiotic for less than 4 days and everything resolved, most likely your patient does not have infective endocarditis, and you can reject the diagnosis, and there's no pathological criteria, and it does not meet any clinical criteria for infective endocarditis. So like I said, definite endocarditis is the possible endocarditis and rejected endocarditis. And this table just puts together the new changes that was made onto the Duke's criteria and the classification of the organism into the typical. There are new additions to the typical organism apart from our Staph aureus and the others, and the changes on the imaging and the surgical major criteria. So I will just quickly run through the European Society algorithm for diagnosis, so that we can just see. So when you suspect a patient has a native valve infective endocarditis, and you have taken your history, you have done your examination, done your culture, you have done your echo, and you have used the updated Duke's criteria. So if you have a definitive, if you have the criteria, maybe you have isolated the organism, or you've been able to use your 2 major and all the other, like I said, the 2 major criteria, 1 major plus 3 minor, and or 5 minor. So you have a definite diagnosis. So what do you need? You need to go on with your treatment. But if you suspect that the patient might have paravalvular complication, like I talked to you about, that cardiac CT is better in that one. So patient may need to do a CT. And if you have extra cardiac manifestation, then the patient might need to do other scan, brain scan, and as the case may be. But if what you have is a possible diagnosis, then you may need to repeat your blood culture. You may need to repeat your echo within 5 to 7 days. And if your echo is still inconclusive, you may need to do your cardiac CT to be able to look at what is happening in the heart. The same with prosthetic valve endocarditis. It also follows the same thing like in native valve endocarditis. So this for patients where you are suspecting they have infective endocarditis associated with implantable cardiac device. So if you have the criteria to definite, you treat your patients with antibiotics. And if it is possible, you repeat the blood culture, repeat your echo, and the patient may need to do cardiac CT and PET scan if it is available. But if it is rejected, you look for other diagnosis. And going to treatment, the treatment of patients with infective endocarditis is multidisciplinary, and early commencement of antibiotics is what will reduce the mortality and morbidity in this patient, and some patients might actually need surgery. So it's a multiple team that is involved in endocarditis. So cardiologists, surgeons, imaging, because we talked about images, microbiologists, infectious disease specialists. Then we have other adjuncts, our pharmacists, radiologists, and other guys are also there. So like I said, you need to start your antibiotics as early as possible. And when you are starting IV antibiotics with high bactericidal activities, and I will not be able to bore us with all the antibiotics. They are all available in the guideline, where you have the combination that is used to treat this patient. If cardiac surgery is indicated, you must start within that first 10 days. And if it is the one that is associated with an implantable device, you must remove that device immediately. And where you have all the paravalvular complication, where there is abscess, it must be drained for the patient to get better. And you do that within that first 10 days as early as possible. Then after the day 10, what do? You perform an echo. You do a transesophageal echo. when you do, after doing that, and you can see that, okay, there has been an improvement from what we have at the beginning, the clinical symptoms is also getting better, then you now have options. The options you have is, if the patient is getting better and you can see that, okay, you can either transit to an outpatient parenteral antibiotic therapy, where you allow the patient to go home, but the patient still continues to be on parenteral antibiotics. Or the new guideline has allowed the use of oral antibiotics after that day 10, when you have performed your transesophageal echo and you have seen sign of improvement. But when you have complicated cases where instead of the patient getting better, the patient is not improving, the paravalvular complication is even getting worse, that patient needs to remain in the hospital and you need to continue your IV antibiotics. And like I said, the treatment is at least between 2 to 6 weeks for patients with native valve endocarditis and 6 weeks or more with patients with prosthetic valve endocarditis. So this is just a table showing, okay, before your culture result comes out, the empirical antibiotics you can use for this patient. And like you said, you can combine ampicillin with the combination that is, so ampicillin in combination with ceftriaxone or with flucloxacillin and genticin. So combination of this, and the doses are stated on the table. And so, how do you assess that the patient is getting better? So, what do? The fever is coming down, your CRP is going down, your white blood cell count is going down. So, those are signs that your patient is getting better. And is there any other indication for continuous use of IV antibiotics, and you perform your transesophageal echo and everything is looking good? So you can switch the patient to either outpatient IV, or you can switch the patient to oral antibiotics. But if the blood culture is still positive, there's no change, the fever is still there, all other factors you measured are still elevated, then you need to continue your patient on IV antibiotics. And this is just showing indication and timing for surgery. The main indication for surgery in them is to treat heart failure, when you have uncontrolled infection despite use of antibiotics, and to prevent embolism, septic embolism. So you have your patient showing signs of heart failure, pulmonary edema, despite your treatment, then there might be need for surgery to correct all those valvular abnormalities. Despite the use of antibiotics, it seems that you can't get rid of all those paravalvular abscess, and so you might need to do surgery to drain those abscess. And when you have very big embolus, highly mobile, that can break off and lead to distal embolism, that patient needs to have surgery. And your surgery can either be urgent within the first 3 to 5 days, or it could be delayed if there is opportunity for that to happen. And when you have treated your patient with antibiotics, your patient can get better and your patient can relapse if it's still the same species of the organism that you are still getting after initial relief, then it's a relapse. But if it's a different species, then it may likely be a reinfection. And these are factors that increase the rates of relapse. If you don't treat with antibiotics very well, if you are dealing with resistant organism, if there are perivalvular abscess, extension, and all those other things listed on the table. And for patients with electronic device, like I said, once there is culture positivity, you must pull out the device immediately. And for those that want to implant, you should give them prophylactic antibiotics before you do the procedure. And in HIC, we do 1 gram of IV ceftriaxone about 30 minutes before the procedure. So for patients with high and intermediate risk, you need to do prophylaxis for them, especially when they are going for oropharyngeal procedure. For other procedure, the recommendation is not very strong again for the use of prophylactic antibiotics. But for patients with going for dental procedure, even if it's just dental extraction, and they have high and intermediate risk for infective endocarditis, you should give them prophylactic antibiotics. And these are the patients with high risk for infective endocarditis, previous history, patients with prosthetic valve, patients with congenital disease, patients with ventricular assisted device. Then those with intermediate risk are patients with rheumatic heart disease, patients with degenerative valve disease, and patients with hypertrophic cardiomyopathy. And you should give them general preventive measure, oral hygiene, taking care of their wound. They should not do tattoo, they should not do piercing from where they can get bloodborne infection. There should be limitation for use of catheters and invasive procedure as much as possible. And like I said, when they are going for all this oropharyngeal procedure or orodental procedure, they should be given prophylactic antibiotic. And these are the antibiotic regime that you can use for them. Like I said, most of them in HIC, we do ceftriaxone 1 gram about 30 minutes before their cardiac device implantation. And then, like I said, mainly in dental procedure, oral procedure, but the use of systemic antibiotic prophylaxis for other conditions, not very strong. It's a class 2B recommendation by the ESC. And when they are going for procedure, cardiac procedure, ideally, the theater staff, the doctor should be screened for staph aureus, and if any carrier is found, should be treated. And the standard aseptic measure should be observed when they are doing any of their procedure. So, in conclusion, infective endocarditis is a severe condition. Like I said, there's been a lot of updates in the affected population, in the diagnostic criteria, adding new imaging modalities, adding new lab technique where they are available. And like I said, prompt commencement of antibiotic, involvement of surgeries when patient has heart failure, when you cannot control the infection, and when there is high risk of the vegetation breaking off and being sent to other sites. So we should also not forget the importance for prevention and the use of prophylaxis in high and intermediate risk patients. So these are my references. Thank you for listening. I hope I've not taken your time and I've not bored you with a lot of jargons. Thank you. So time for questions and comments.
Thanks a lot, Dr. Ola, for this comprehensive presentation. That was a very great revision on this hot topic, the infective endocarditis. Yes, and we made a lot of benefits, like, of taking those notes about the new recommendation about, like, the culture negative infective endocarditis. I will not be discussing the thing scientifically, but yeah, definitely we can see this many times, especially with the prosthetic valves and devices and so on. And my cousin himself, like, he had a aortic valve before, and he replaced before, like 10 years ago, and then all of a sudden it started to get a high fever that was not explained. So they did an echo. The echo didn't show anything. So the doctor at that time like thought that this is might be like tonsillitis or something else. I insisted to do like the transesophageal echo that showed like paravalvular infective endocarditis plus a leak over there that was not detected by the regular transthoracic echo. And also they did a CT scan that confirmed the diagnosis and also the site of the vegetation. And it was a little bit complicated because he took some time until he was like discovered to have the infective endocarditis. So this is very, very important like point that we have to make some suggestions to those patients if they don't have any previous like rheumatic valvular heart disease or any or they are not known for that. Meticulous examination, check for any new valve murmurs or anything, and also like if they are not responding to antibiotics, echo is a very important tool, as you mentioned, so we can diagnose this. Also, the very important topic is the IV addicts and so on, to watch for the tricuspid infective endocarditis, which we saw like quite a few people that may present also with very high grade fever for a long time and so, and they were not suspected to have like such thing. So we need to understand that this also can happen, and echo would be a very useful tool to diagnose such patients, and also like not to waste time if we're not very, like quite sure of the echo findings. We like refer the patient for transesophageal echo, because time is very, very important in those patients, because sometimes it can be lethal. Also, we have to emphasize on the not the antibiotic abuse nowadays, because also we are using very heavy antibiotics, and sometimes they are not sensitive. The organism sometimes is not sensitive because of the resistance that start to develop with for the even the new antibiotic agents nowadays. So we must be very cautious in prescribing like antibiotics, to reduce that kind of resistance. Again, thank you, Dr. Ola, for this very elegant and comprehensive presentation. And we are open now for any questions. Please feel free to ask.
Hi, Dr. Ola. Thank you for your excellent presentation. It's Mark Williams here. I missed the first part of your presentation, so I'm not sure if you presented the young guy that we saw a couple of weeks ago.
Not really, not really.
So we had this, I think it's 24-year-old gentleman who came with his mum, who basically presented in heart failure. He had an echo done at St. Elsewhere, and their report said he had moderate aortic regurgitation, which clinically that clearly wasn't the case. So we re-echoed him. I mean, he hadn't given a history of a fever or anything like that, but we re-echoed him because clinically he had severe AR, and the echo that we did shows severe aortic regurgitation, dilated left ventricle, and he obviously was in failure. Obviously I cathed him and obviously referred him for surgery. Went across the UE to have it done because obviously our perfusist wasn't here, but had blood cultures done because there was actually something looking at the valve, looked as if there was a vegetation there. And he's obviously grew positive blood cultures, and obviously this was a feature of someone who had a bicuspid aortic valve, probably not detected before, got infection on the valve and developed quite acute severe AR and with heart failure.
Thank you very much. I didn't even see that case. I know some of the challenges we may have here is with our culture, the blood cultures, to be able to isolate those organisms. I think that is the laboratory backup is one of the biggest challenge in the diagnosis of infective endocarditis. But I think if we can make the habit of doing both transthoracic echo and transesophageal for patients with high-grade fever and the presence of all those cardiac risk factors, I think we may be able to pick more patients with infective endocarditis and may be able to help them with surgery to prevent worsening valvular complication.
Thank you.
Williams, so he was having fever on presentation, or that was a history of fever before?
No, there was no history of fever. He basically became breathless, and so had an echo. I think was it Heart Foundation. I think he had an echocardiogram done. So, and they referred him to us to investigate why he was getting so breathless. But their echo they reported it as showing moderate aortic regurgitation. Well, clinically it was clinically
with
clear.
collapse.
The dilated left ventricle. And he talked about something. It didn't mention abscess in their report. I can't remember what they said in the report, which didn't really make too sense. But thankfully, we obviously didn't depend on, because we never had any images. So we re-echoed him, and his AR he had free flowing AR with dilated LVs, had peripheral edema, which had started and had developed over the previous 2 weeks.
And you're saying that he was having a bicuspid aortic valve?
Yeah, a bicuspid aortic valve.
It's sometimes confusing if you don't see like a vegetation mass or something. It might be sometimes a ruptured coronary sinus.
Yeah.
With dilated like aortic root and so on. Yeah, it's confusing. And as Ola just mentioned, transesophageal echo is to get to dig it deeper a little bit to find out what is the real cause. If it's vegetation, definitely the infective endocarditis root. If it's coronary sinus rupture of sinus valva or something, it can be.
He did have positive blood cultures.
He had positive
blood cultures.
Without fever, he's not immunocompromised.
We never recorded the fever. He went because he basically was going to be kept in for surgery. But obviously, because the perfusionist wasn't here, Joseph took him across the UE, and so we cultured him there and grew. I don't know what organism they grew, but obviously started him on antibiotics in conjunction with the infectious diseases team.
Well,
so he had surgery last weekend.
Yeah, we have Dr. Blidgen here, definitely.
Yeah. So Mark is correct. So when we saw him there. However, when you delve in the history a little bit more, when he came up to UE, he gave a history of fever some time ago, malaise, fatigue, and weight loss. After we saw the echo, and we actually took him to the university, and we did blood cultures, and all the bottles grew Streptococcus salguinis, which was sensitive to vancomycin and ceftriaxone. But when initially started him on 2 grams of ceftriaxone and gentamicin, his CRP was elevated. ESR was, I think, 80 or something like that. He had wide open AI, as Mark was saying, and was in heart failure. So we actually operated on him, but we did a culture like a couple of days after the start, antibiotics before surgery, and that was actually negative. So we took him in, and basically, as Mark said, he had a bicuspid aortic valve, but he had total dehiscence of the right coronary cuff. That basically was just totally, almost just maybe about maybe about 0.5 centimeter of what was left behind was attachment. We thought initially when we did the TEE pre-op that there was a vegetation possible on the anterior leaflet of the mitral valve. But what it was intra-op was that this anterior cusp was just swinging up and down, and sometimes was below the annulus of the aortic valve, which was almost anterior to the anterior mitral valve, anterior leaflet of the mitral valve. So we actually replaced, give him a mechanical valve, Onyx size 23, which is quite good based on his height and weight. And he had to come off pump with a liquor inotropes, but that was weaned after about maybe about 8 hours in ICU and extubated early. So far, the intra-op cultures of the tissue that we have sent to the lab shows no growth, and that's about 2 or 3 days now. And he's back on the ward, still getting the sensitive antibiotics, which is the vancomycin. CRP is actually coming down. The ESR is also coming down quite well. He has remained afebrile. He's up and about, walking up and down. So the plan basically is to complete at least 3 to 4 weeks of IV antibiotics, and then possibly put him on another 2 weeks of augmenting as outpatient. Depends, of course, what the CRP measurement and the ESR suggests with our next couple blood testing. His white cell count was about 14. It's now down to, I think, 10. So we think he's moving in the right direction. But those were the findings at surgery. But as Mark said, he was in frank heart failure and just wide open here, quite breathless, unable to move from point A to point B without resting on a chair. So we just, based on all the cultures, as well as, initial sterility, we had a long discussion with the family about prosthetic valve endocarditis based on the fact that he had not completed normal 4 to 6 weeks of antibiotics before, in which we'll be happy to do, but based on his state, we had to take him in. And so that's something that we have to keep in mind. Although the cultures before and the intra-op cultures are negative, and we still have to engage with them about prosthetic valve endocarditis, whether early or late, as part of the discussion. So that's where we're at with him.
Thank you.
Thank you.
Okay. That's a great case, Dr. Blidgen, and definitely, what you did, Williams, was the right thing. By mentioning the prosthetic valve endocarditis, so what's your regular practice, Dr. Blidgen, if something like, God forbid, something happened like that? So how you proceed with dehiscence or with the paravalvular leak or something like that? How you proceed from there?
Well, the thing about it is that if we do if we present, I will do all the investigation, and it suggests that the valve is either rocking or if there's a paravalvular leak, we actually take the valve out. We'll give him antibiotics, but we take him to the operating room and we take the valve out. The question is, what is ideal in terms of this case? Should we give him a bioprosthetic valve? Should we give him an OMA All of those things we usually think about. But based on our setting, we normally usually repeat we give them a mechanical valve depending on the age, or basically we have a long discussion with them and possibly give them a bioprosthetic valve. But usually if there's a paravalvular leak in terms of prosthesis, we usually take out the valve.
So you take it immediately, or you just like give some time for the antibiotics first? Right.
So there are two. I mean, if he's relatively stable, then we'll continue with some antibiotics until he achieve maybe about 4 weeks, and whether or not the blood cultures are sterile, etc. However, if he's unstable hemodynamically, then we usually go in and then either give the antibiotics for an extended period of time after. Depends, of course, on the organism, whether or not it's the bacteria or fungus. If it's fungus, it's lifetime antibiotics. However, if other things, we go according to the protocol. But it depends on the degree of stability and heart failure symptoms the patient has, whether or not there's also evidence of renal impairment, all the necessary stuff, low cardiac output, all of those things, we will operate as quickly as possible.
How about did you see any, I'm sorry, did you see any of the new, like the TAVI prothesis? Did you see any infective endocarditis on TAVI prothesis?
Well, I haven't seen any local. I mean, we have read in the literature that it exists, and usually these, we actually, and when I was away, we actually just remove them once they're infected, because almost the entire leaflets are usually destroyed. But locally, we have not seen any.
Okay, great.
Okay, please, Dr. Blidgen, if you have any of these acute cases and with a significant coronary artery disease that needs cabbage. Can you go ahead and do it in that acute phase, or you have to wait till you give them that 4 weeks of antibiotics?
Well, it's something that we actually think about. We weigh all the primary, well, we look at the patient and everything like that. We sometimes just go ahead and do one major surgery, because and then the necessary things like balloon pump if needed, and inotropes if it's needed, all the necessary stuff. So it can be done, but usually, like in this case where Matt did, and the coroners were normal, we were quite happy. But if in cases where there's associated coronary artery disease, then we do everything at the same time.
Okay.
I was going to mention also about the TAVI patients, because presumably TAVI is normally put in patients that are not good surgical candidates in the first place. So what would be the
well
there?
No, I totally agree with you, because but as you know, the guidelines for TAVI actually is changing in terms of the risk and of insertion. I remember many years in my training, it was for patients who have less than 6 months to live, renal impairment, stroke, and all of those things. Now with the different studies that have been around, the indication is really is widespread, and even in some cases off the shelf indication. And we have noted that in sometimes even in despite what the literature say, in young patients, it's an attractive cell, and even locally, to get this, just a little pinch in the lower groin, as we'd seen on the television, and a little pinch on the groin, and much better than cutting your chest, despite the fact that the guidelines are quite clear in terms of age. But I think you're perfectly correct, Mark. The fact is that, the indication for TAVI, usually elderly patient over 60, patients who have significant comorbidities, reduced life, severe stenosis, but reduced life expectancy. And so, but in cases where it may have gone in a young patient and subsequently infected, we'll take it out.
Okay.
Okay, we have a question what's the factor that make males more prone to infective endocarditis than females, from ratio provided in Ola's first introductory slide? Dr. Ola?
I think I put something in the chat box. Those are findings from epidemiological studies, and actually no reason has been given for that slight male increase ratio, which is just about 2 to 1. So there is no hormonal factor, but I think it's just what it is in terms of affectation. Maybe there could be some sex predilection in the terms of maybe some valvular lesions, and as it relates to age. But apart from that, I've not seen any real factor that could be attributed to that slight increase in the male affectation.
Great. If there's any other questions? Okay, so thanks everyone for being with us today, and thank you, Dr. Ola, for this great presentation. Thank you, Dr. Williams and Dr. Blidgen for your great contribution. And we hope to see you next week in our weekly conference. So stay tuned for that. Okay, thank you.
Thank you.
Yeah.
Thank you. Bye.